All right, hello everybody. Kohei and I are very excited to get started with this session. So I guess, we all know that clonal hematopoiesis is a really hot topic in general in hematology at the moment, but also in marrow failure. And I think we have a really good session here that looks at clonal hematopoiesis and all aspects of marrow failure. So we have disease-specific talks given by a range of speakers. Two of our speakers will be remote, and we have three who will be in session. And the plan we have is that we'll have the speakers give the talk, and then we'll have a general discussion at the end. So if you can hold your questions for the discussion, that would be great. Kohei, do you have anything you'd like to add?
Hi, nice to meet you. I'm Kohei Hosoka from Canada University, Japan. So first, I'd like to introduce the first speakers. Simona Pagliuca from the Nancy University, France, and her title of her talk is about clonal evolution in immune bone marrow failure. So she's from. Could you start?
Yeah, and she's coming in remotely. Unmute. Unmute, Simona. Simona, you're muted.
Hi.
There you go, perfect.
Perfect. Thank you very much for the kind introduction. Can you hear me well?
Yes.
Okay, perfect. So I'm really excited and thank you very much for the invitation to discuss about this topic. I really do apologize for not being present in Bethesda today, but I'm sure you are enjoying a great meeting. So I will try to do my best to give you an update on the clonal evolution in immune bone marrow failure disorders, and this is the outline of my talk. I will touch some definitions and clinical, epidemiological, and molecular background of clonal evolution and clonal hematopoiesis, and to finish with practical aspects and open questions. So we are talking about immune-mediated bone marrow failure. We know that we are talking about a non-malignant disease in which the immune system, in particular with the T-cell-mediated physiopathology, is all engaged to destroy the hematopoietic stem cell compartment with hematopoietic stem cells that need to adapt, to react to this autoimmune insult. And they can have this adaptation through several possible scenarios. With in particular cells that need to be able to survive and to have a survival advantage to this autoimmune attack. We know all about the proliferation of PGA mutated cells with a more or less overt PNH phenotype. We know also that there is the possibility of the destruction of stem cell and progenitors compartment without recovery with a completely aplastic phenotype. We know that there is the possibility of a proliferation of HLA mutated clones, evading the autoimmune attack, both in aplastic anemia and PNH in several disease phases. And of course, there is the possibility of mutated leukemic clones that acquire a survival or a proliferation advantage with an overt phenotype of MDS or AML. But on the top of that, there are many intrinsic and extrinsic influencing factors, such as age comorbidities, HLA background, pathogen exposure, and also genetic and immunogenetic predisposition, as we have seen in the wonderful talk of this morning, with, of course, the bottleneck effect of the immune suppressive therapy that could shape all these trajectories in terms of clonal evolution scenarios. But the bottom line is that clonal hematopoiesis does not mean necessarily clonal evolution. So the association among aplastic anemia and PNH and MDS was known since a long time. You all remember the Dameshek riddle, and one key of for interpretation of the riddle is that the clonal hematopoiesis represents the adaptation to the immune insult. If we want to give a definition, so we define clonal hematopoiesis as a fraction of hematopoietic cells that originate from a single stem cell or a multipotent hematopoietic progenitor and that can be detected by identifying somatic lesions. And of course, our capacity to detect these molecular aberrations has changed over time with cytogenetics and with today all the high throughput sequencing techniques that are able to identify molecular lesions also in portions that are very complex in the human genome, such as the HLA locus. Clonal evolution is instead intended as the diagnosis of an overt myeloid neoplasia with signs of dysplasia, fibrosis, or blast proliferation associated with these molecular lesions. But what is the prevalence of clonal hematopoiesis in immune-mediated bone marrow failure? We can say that since we started to analyze and to sequence and to genotyping all was moving in terms of immune-mediated bone marrow failure, we found that this was actually the rule more than the exception, including also in pediatric patients, with many series of patients that have been sequenced with several techniques in which so the prevalence of clonal hematopoiesis has shown as high as 70% of patients. But we have some specific patterns that characterize clonal hematopoiesis in aplastic anemia that are also different in normal aging process or MDS. And here you have a beautiful picture showing the relative frequency of recurrent clonal abnormalities in all these scenarios. In particular, you can see that in acquired aplastic anemia, PNH cells, the 6p loss of heterozygosity, some clonal aberration associated with A6L1, BCOR, DNMT3A, and also cytogenetic abnormality are present, and that they can characterize the scenario of acquired aplastic anemia as compared to MDS and normal aging. But what are the clinical correlations and the clinical impact of this somatic mutation in aplastic anemia? The first studies that profiled a large cohort of patients from NIH and Japanese cohort, but also the English study from Kulasekararaj and colleagues, showed that actually there is in these patients a very high frequency of mutations in genes such as BCOR, BCOR-L1, DNMT3A, A6L1, besides PGA mutations. And there is also an impact in terms of response to immune suppressive therapy, an impact in terms of survival outcomes with mutations identified in PGA, BCOR, and BCOR-L1 associated with a better prognosis. But what we have learned with the RACE trial in 2022, actually, you all know this trial. It changed the therapeutic landscape of aplastic anemia and actually represented also a unique opportunity to assess the clonal hematopoiesis in precise time points of patients undergoing immune suppressive therapy for anaplastic anemia. And now we are able to see that at baseline patients, at least 30% of patients present with a clonal hematopoiesis with at least one mutations, with these rates that increase over the time after the immune suppressive therapy. And of course, one important thing was that in this trial, there was no difference in terms of clonal hematopoiesis and somatic mutations in both groups of treatment. In particular, no association with survival or response, no association with progression to MDS or AML, but we need to acknowledge that no long-term data are available yet, for which we are waiting for the long-term results of RACE2 trials. So the question was whether L-thrombopag could impact on the incidence of clonal evolution. And actually, already with RACE trial, we had this the response, an answer to this question. These data that were validated also in parallel by the long-term outcomes of therapy of immunosuppression with the thrombopag in this phase 2 NIH trial, comparing actually patients treated with the thrombopag and an historic cohort receiving immune suppressive therapy. And actually here, so there was no difference in terms of high-risk evolution and in terms of relapse. But what about HLA escape? We know that this mechanism that is shown, that has been identified in solid tumor as a way to escape from the anti-tumor surveillance, and that is identified also in many hematological disorders, is important in the physiopathology of immune-mediated aplastic anemia as a mechanism of rescue of the hematopoietic stem cells from the immune attack. There is a plethora of studies exploring HLA loss, HLA also downregulation, either with genomic profiling or transcriptomic and epigenetic studies in aplastic anemia and PNH patients. But there is also discordant literature in terms of the clinical impact and the biological significance of this mechanism of clonal expansion. And in particular, the important question is whether this could facilitate or not myeloid progressions. And many of these studies we need to acknowledge that have been conducted in different cohorts of patients, also with different age, with different clinical background, and also the way to detect these molecular lesions have been different over the time. So this could be one reason for the discrepancy that we have in literature. I want to talk about the myeloid somatic mutations in PNH patients because there is a talk in this session, but I would like to spend some words concerning these aspects of the spontaneous remission in PNH. In particular, we know that this is a rare event, accounting for 1 to 15% of patients according to different series of hemolytic PNH. And our effort in Cleveland Clinic was to try to understand whether actually this particular event could be associated with a particular genomic profile of these patients. So we took all majority of the patients diagnosed with an hemolytic PNH in Cleveland Clinic institutions, and actually with the myeloid and HLA genomic profiling, we were able to find 3 patients that actually had the disappearance of PNH clone, but this disappearance corresponded to the appearance of the myeloid, the emergence of the myeloid mutated clones. So here, none of these patients underwent the diagnosis of MDS or AML, but we feel that the combined follow-up of PNH clone and clonal hematopoiesis may be interesting in these cases. Concerning the clinical, epidemiological, and molecular aspects, the incidence of malignant clonal evolution in idiopathic bone marrow failure has been dissected in many studies and has been found as high as 10 to 15% of the cases of aplastic anemia in PNH patients that have been found to develop myeloid neoplasia during their follow-up. And here there is our multicentric effort together with the Cleveland Clinic Institution, Hospital São Luís, and the Ribeirão Preto in Brazil to try to assess all the molecular and clinical determinants of malignant clonal evolution in aplastic anemia in PNH patients. We were able to collect clinical and molecular data of more than 1,000 patients. And we were able also to identify the long-term 10-year cumulative incidence of post-aplastic anemia myeloid neoplasia that was at 11% for a median follow-up of more than 8 years. And we were able also to show that patients undergoing a transplant never developed a clonal evolution event. And we reconstructed the risk factors, the prognosis factors associated with the progression to MDS AML. In particular, we found that poor response to immunosuppressive treatment and age were the most important risk factors associated with progression, while no impact of myeloid mutations and diagnosis was found in terms of progression. Focusing on the evolution to secondary PNH, so this was found in the 10-year cumulative incidence was 9% in this cohort, and actually the risk factors for progression were identified in response to immunosuppressive therapy, sex, and the presence of the PNH clone at diagnosis, so for the cumulative incidence of secondary PNH. When we focus only on the clinical and molecular characteristics of the patients with the myeloid neoplasia after aplastic anemia and PNH. So we identified 94 patients in this cohort. We can see that all these patients had the high-risk profile with high-risk cytogenetic lesions, in particular monosomy 7, chromosome 7 abnormalities, and were more frequently patients that had the severe aplastic anemia phenotype at diagnosis, that were not responding to immunosuppressive therapy, and who received at least 2 treatment lines. And most of them had at least one myeloid mutation at diagnosis. Here, the molecular landscape of these patients, in particular, I wanted to focus on this waterfall plot showing the frequency of mutations at the diagnosis of myeloid neoplasia evolution with A6L1, RANKS1, ZBP1, and also the NMT3A as the most frequent lesions. And concerning, of course, the clinical outcomes of these patients, we are talking about outcomes that are very poor in this population. After progression, we had a median follow-up of 5 years with a 5-year survival rate of 40% with bone marrow blast at diagnosis of progression as a strong prognostic factor. So to conclude with some practical aspects and open question, late clonal complications we have seen are not so infrequent in patients with aplastic anemia and PNH, and follow-up of PNH clone of a bone marrow evaluation every at least 12-18 months seem to be reasonable, at least with cytogenetics and if possible with myeloid NGS to early detect the signs of clonal evolution. We have seen that transplant can abrogate the risk of clonal evolution, and we have seen also that the presence of clonal hematopoiesis and CHIP represent a common situation even at diagnosis that is not necessarily associated with the malignant evolution, and it can be highly dynamic and it can require a cautious interpretation in the context of other clinical factors. At the moment, it is not possible to establish treatment recommendations, and every situation needs to be discussed on a case-by-case basis, and of course, the discussion of an allogenic stem cell transplantation should be on the table whenever possible. Just to finish with some open questions, so how can we improve the risk stratification at the moment of clonal evolution? The beautiful work from NIH by Emma and colleagues proposed this classification of high risk and low risk profiles of clonal evolution, defining their risk as the presence of an overt myeloid neoplasia or chromosome 7 abnormalities or complex karyotype with or without MDS in men. And of course, this classification could correlate with clinical outcomes. We tried to explore the role of molecular tools such as the IPSS, but no improvement in prognostic terms was found as compared to the old IPSS-R, since also the majority of these patients already had an unfavorable cytogenetic risk diagnosis. The other question is, what is the role today of TPO agonist and of Beltrombopag? Today, we can say that there is no evidence of robust association with clonal hematopoiesis with progression, but of course, long-term prospective data need to be analyzed. I feel to say that we still don't know also the role of HLA clonality because of this discordant literature. We cannot do a clear statement regarding the facilitation of progression to MN, also because we don't have a standardized method to track HLA mutated or lacking clones. Concerning the spontaneous remission in PNH, could we consider them as another form of clonal evolutions? We have seen that those are rare phenomenon. The nephew series are associated with the appearance of myeloid clones as a means of clonal substitution. So it appears to be important to assess the clonal hematopoiesis in this context. I would like to thank everybody for the attention, and in particular all Jarek's lab, with whom we did a lot of work in this setting, and all my colleagues from Nancy University Hospital and the University of Lorraine. Thank you so much.
Thank you very much. So as I said, we'll be holding questions to the final panel discussion. So next up, I'm delighted to introduce Dr. Jani Huuhtanen from the University of Helsinki, who will be speaking to us on the role of lymphoid clonal hematopoiesis in immune bone marrow failure and LGL.
Okay, thanks for the chairs for the kind invitation to come here to present our work, perhaps from a bit different aspect of what the previous discussions have been. So in the 1970s, people were just starting to realize that cancers are formed by different mutations, but around that time, the Nobel Prize winner McBurnett was already thinking about, are also autoimmune disorders caused by mutations in the immune cells, and he quite strongly believed in that. Of course, McBurnett did not have technologies that we have today, and even the technologies that we've had around for some like 20 years or so, so-called bulk methods, are more likely to miss these mutations in the lymphocytes because of the low variant allele frequencies. So the advent of these single-cell methodologies, where we can study increasingly number of different omic techniques alongside the RNA and DNA, has really changed the scene. So after this, these mutations in lymphocytes have been linked to many different phenomena, including lymphoid malignancies, autoimmunity, and cellular therapies. We will go through these one by one, and I will highlight some of the most interesting studies. But first, some definitions. So in normal CHIP, the mutations are often thought to occur at the more premature hematopoietic stem cell stage, and that is because myeloid cells are not that long-lived, and they don't possess the proliferative capacity compared to, for example, lymphocytes. In lymphoid mutations, the mutations can occur at the precursor stage, or then at the later, more mature T cell stage, where all the T cell clones harbor the mutations. And our work focuses perhaps more on the latter of these phenomena. Perhaps the most expected thing in lymphocyte mutations is their association with lymphoid malignancies. And MBLs have been shown to carry the same mutations as stable CLL. And seminal work by Nirola et al. Showed that CLL risk is higher with individuals with these so-called lymphoid chip mutations. So they analyzed the UK Biobank data, and they devised the chip mutations into myeloid chip or lymphoid chip. And myeloid chip was mutations like TET2 and DNM3A, which are more permissive in the monocytes. And the lymphoid chip was more of these lymphoid mutations like MUD88 and such. They were able to recapitulate that myeloid chip is associated with a higher chance of developing myeloid neoplasia, but this lymphoid chip is associated with a higher probability of gaining lymphoid malignancies, and they denote the lymphoid malignancies here as CLL without MBL. What we have done with Satu Mustjoki's lab quite a bit is the association of lymphocyte mutations in autoimmunity. And the story started with LCL leukemia, where the mutations in the STAT3 was first discovered in Helsinki. And the STAT3 mutated patients seem to have a lot more rheumatoid arthritis than the patient with wild-type STAT3. And this led us to pursue what is the case with newly diagnosed RA patients without LCL leukemia. It turns out that there wasn't, at least based with those better, not that modern technologies, but we were still able to see some mutations in the CD8 T cells. That led us to pursue the aplastic anemia because the diagnosis can often be concurrent, and we did indeed find mutations in the JAK-STAT pathways. After that, collaborators here and elsewhere have been identifying these mutations in other associated autoimmunity hematology, but also in diseases like multiple sclerosis and celiac disorders. One beautiful study that I want to highlight is from B cells. So an elegant work from Chris Goodnow's lab where they identified the B cells that are producing autoantibodies to this vasculitis secondary to Sjögren's syndrome seem to have lymphoid driver mutations, and this offers perhaps a link between the highly theoretized link between autoimmunity and developing lymphoma. In Finnish, we have this saying, tekevälle sattuu, meaning that people who do things happen to those. And for example, there was this remarkable case of follicular lymphoma that was seen in the follow-up of a donor and a recipient after 7 years of the initial transplantation, and those lymphomas were genetically highly similar. We have also seen in a patient who had a really difficult to treat chronic GVHD following transplantation, and we noted that the patient had a CD4 T cell lymphocytosis, and in those CD4 T cells, the patient harbored mutations in the mTOR pathway, which caused a highly cytotoxic phenotype for their CD4 positive T cells. This mTOR mutation wasn't seen in the donor, only on the recipient. We performed a drug screening on those CD4 T cells, and we identified that the recipient CD4 cells were resistant to mTOR inhibitors, but highly sensitive to HSP90 inhibitors. One of the big talks in the town is these CAR-positive lymphomas, but I want to also add to these discussions a bit anecdotal evidence that there has been some data from Carl Thune's lab and from Michel Sadeline's lab that mutations that are acquired during the CAR-T in vivo phase, especially in the two, can prolong the persistence and perhaps added cytotoxicity to the CAR-T cells, so not everything is always bad. So LCL leukemia is a good model for somatic mutations in autoimmunity and cancer immunity. So in a normal setting, when a T cell recognizes its antigen, it starts this clonal expansion, and after the antigen is cleared, the T cells suppress and form this memory response. In LCL leukemia, the clone persists and causes different types of autoimmune reactions, different cytopenias. Also, LCL leukemia has been associated with cancers, but their role in malignancies is not well known. If you would want to think about LCL leukemia, it's almost like your in vivo CAR T cells, and I can show you why I think that. So, as it's known, LCL leukemia forms these massive oligoclonal expansions, and one patient can have either one or multiple ones. These clones switch over time and do not always associate with the severity of the symptoms. LCL cells have a clear distinct phenotype from healthy reactive clones, and we can see that LCL cells are more cytotoxic than these healthy reactive clones, and they express quite a bit of these NK cell receptors, meaning that they perhaps can overcome the TCR-mediated cytotoxicity. We also noticed that these LCL cells are also exhausted. They express PD-1, LAG3, and such. And when we try to in vitro stimulate them via the TCR, we cannot stimulate them, meaning that there is something going on. To truly leverage the single-cell RNA sequencing, we identified which clones have the STAT3 mutations and which have the STAT3 wild type. And we saw a bunch of differences between the mutated and wild type ones. And the most important one was the cytotoxicity, which was higher in the STAT3 wild type cases. This was then also validated with bulk RNA sequencing with a larger cohort. This could mean that there are perhaps different etiologies and perhaps clinical pictures with the STAT3 mutated and wild type cases. Like I said, LCL leukemia is a model disease, and we can learn from that. And now we are in the phase of trying to leverage this information to other disorders as well. So aplastic anemia is a good example, as the diagnosis can overlap. Here is just one patient case of a 50-year-old female who was otherwise healthy, but during the winter got hospitalized during an influenza A pneumonia. And during the follow-up, her blood values kept on decreasing, and she was diagnosed with aplastic anemia and started with the basic immune suppression therapy and got quite a good response for that. When we performed single-cell RNA sequencing on that patient, we noticed that the patient had a quite distinct STAT3 mutated CD8 positive T cells. As you can appreciate from the UMAP, they are, oh sorry, perhaps you cannot, I don't know what's going on with the resolution. But yeah, so these STAT3 mutated cells are really different from the CD8 T cells, and they express these NK cell receptors that I mentioned before. After the treatment was initiated, the STAT3 mutated CD8 T cell clone diminished. So that led us to pursue, are these aplastic anemia patients, do they have an overrepresentation of these LCL phenotype cells? So we gathered a catalog of different aplastic anemia cases, healthy controls, and other hematological disorders, and performed single-cell RNA sequencing on the CD8 positive T cells. And the second most populous population was these NK-like CD8 T cells, which can be also thought about these LCL-like T cells. These TEMRA CD8 T cells were the most expanded one in aplastic anemia, but also these LCL leukemia-like cells were the second most expanded ones, and we could also detect them in patients with AML. These cells were highly clonally restricted, and we wanted to identify what are their targets. So we have profiled and collected T-cell receptor beta sequencing data from peripheral blood and bone marrow from aplastic anemia and different similar conditions, and have gathered almost 1,000 different samples. And analyzing it has taken 5 years of pain. With a number of different tries, we have made a scheme to find an aplastic anemia associated fingerprints, which we have reduced to these 200 TCR motifs that are associated with aplastic anemia. We validate these motifs in independent cohorts and associate these motifs with phenotypes and clinical variables. So as I said, we could validate that TCRs carrying these motifs were more numerous and more expanded in aplastic anemia patients compared to healthy controls in an independent validation cohorts. Some of these motifs that are plotted here were publicly found in aplastic anemia patients, where the most common one denoted as this SFG wildcard TTE was found in 21 patients out of almost 100 patients. Interestingly, the most prevalent motif was also enriched to patients with a loss of HLA heterozygosity, making it one of the most interesting motifs in the whole dataset. To understand if these motifs are really identifying aplastic anemia targets, meaning the hematopoietic stem cells, we performed an autologous co-culture of immune cells and hematopoietic stem cells with single-cell RNA sequencing readout. We were able to show that T cells with AA motifs were enriched to the NK-like phenotype. And in these cells, the larger the clone, the more the activation we saw. And when we looked at the clones, individual clones, we could identify that the clones that had these TCR motifs were the ones that were the most activated ones. And interestingly, the clone that got activated the most carried this SFT motif, and we really need to figure out what are these T cells targeting, because this is so publicly found in aplastic anemia, and the computational work is ongoing, and we are trying to identify how could we validate that with the biological methods. So as a summary, somatic mutations are common in lymphocytes and also in precursors, and they have been associated with lymphoid malignancies, autoimmunities, and also in cellular therapies. However, the causation between the mutations and the disease phenotypes is still unclear, and we need to have further work on this. We believe that LCL leukemia is a good model for somatic mutations, and LCL-like cells might be prevalent in other autoimmune disorders as well. And for this, I would like to conclude my talk, and a special thanks goes to my co-first author, Sophie Lundgren, and also in the LCL project to Dipa Parnapatta-Charaya, and to my mentors, Satu Mustjoki and Harri Lähdesmäki. Really glad to take any questions now or later, and thanks for your attention. And a bit of plug, I'm looking for a postdoc, so if you have interesting opportunities, please come and look after me. Thank you.
Okay, thank you for your great talk, and we will move on to the third speakers, Dr. Masanori Yoshida from the St. Jude, and his title of his talk is Single-Cell Approaches in Immune Bone Marrow Failure. So Dr. Yoshida, could you start?
So first, I'd like to thank the organization committee for having our study in this session. Today, I would like to present our single-cell proteogenomic data in immune-mediated bone marrow failure. As you all know, the main pathogenesis of immune-mediated bone marrow failure is an autoimmune reaction in which T cells attack HSPCs. Some HLA alleles are known as risk factor of the aplastic anemia development. HLA loss, PNH, and CHIP MDS are known escape mechanisms from bone marrow failure. HLA loss includes loss of function mutations in HLA genes and UPD6B. Resulting from loss of risk allele, HLA loss is thought to be adaptive clonal expansion. Meanwhile, PNH and CHIP MDS often show pathological significance. So, the alterations that indicate that HLA loss, PNH, and CHIP are sometimes identified in the same patient at the same time point by conventional tests. Therefore, there are several open questions. First, do these abnormalities occur independent of each other? Second, does HLA loss cancel risk allele at the single cell level? Last, how does the clone acquire the stability for long-term fitness? Resolving these questions is quite important for clinical decision-making. So we performed the single-cell proteogenomic analysis. So this figure shows the brief workflow of tapestry single-cell proteogenomic analysis. First, sample cells are stained with 42 cell surface antibodies labeled with oligo tag. After encapsulation, each stained cell is sliced in each capsule. Then, both genomic DNA and oligo tag are labeled with unique barcode in each capsule. By using this unique barcode and DNA custom designed panel, we can evaluate targeted genomic alterations and cell surface markers at the single cell level. This is the gene list that we included in our panel. In addition to HLA genes, we included the genes frequently mutated in aplastic anemia or MDS. Also, to identify copy number variations including UPD6B, we selected common SNPs from normal database. So this figure shows how to identify UPD6B. In the single-cell panel, we included 80 SNPs on chromosome 6p with a high probability of being heterozygous. With reference to single-cell genotyping data, I manually picked up 4 to 10 heterozygous SNPs in each case. The figure on the right shows the example with 10 heterozygous SNPs. In non-UPD clone, all SNPs from 1 to 10 are heterozygous. Meanwhile, in UPD clone, SNPs from 1 to 8 change from heterozygous to Y-type or homozygous. So in this case, we can say the clone has UPD at least on the region from SNP 1 to 8. The cohort for this study includes samples from 4 institutions. To include various samples, we manually chose the samples with multiple alterations by clinical test or previous studies. In addition to aplastic anemia, we included patients with RCC, refractory cytopenia of childhood. Among EVOC RCC cohort, to include cases with pathologically immune-mediated aplastic anemia, we selected a patient without known inherited bone marrow failure syndromes and advanced MDS. Overall, we analyzed in total 29 patients, including 18 pediatric patients and 11 adult patients, and 3 healthy controls. In addition to single-cell analysis, we performed SNP array and error-corrected deep sequencing. This figure provides a summary of the clonal alterations in this study. X-axis shows shows each patient, and Y-axis shows the clonal alterations. Dark blue indicates multiple clonal clones within the same patient, while light blue indicates single clone. HLA loss was identified in 9 patients, including 4 RCC patients. Interestingly, 8 out of 9 patients with UPD had multiple UPD clones. PIK-A mutations were identified in 9 patients. CHIP clones were identified in 10 patients. Next, to address open question number 1, I'm going to show the clonal independencies by showing these representative cases with multiple alterations. The first case is a pediatric patient with aplastic anemia. In the sample 3 years after diagnosis, about 90% of genotype cells were Y-type. Additionally, mutations in PIK-A and DMT3A were identified as independent clones. Next, in an adult patient with aplastic anemia, UPD6B and TET2 were identified as independent clones. So most alterations identified in this study were independent clones like these 2 cases. However, lastly, I'm going to show an exceptional case. This is another adult patient who had 4 different UPD clones and 1 PIK-A clone. Interestingly, in these patients, a DNMT3A mutation was identified in one of the UPD clones. So as I showed here, most mutations in each case were identified as independent clone with exception. Next, I'm going to show if HLA loss canceled HLA risk allele by showing this case. This is a 10-year-old girl with severe aplastic anemia. This patient had an HLA risk allele 0201. SNP array showed unclear breakpoint of UPD. In addition to Y-type clone, single-cell analysis revealed that this patient had at least 2 UPD clones with 2 different breakpoints downstream of HLA-A. Also, I identified 2 different clones with HLA-A loss of function mutations. Next, I checked if UPD6B canceled the risk allele 0201. To confirm that, I selected another SNPs on HLA-A and 1093 plus 7. The SNP is C for 0201 allele. Meanwhile, it's T for 2402 allele. When I checked the SNPs on this position, non-UPD clone had both C and T. Meanwhile, both UPD clone had only T. So I concluded that UPD6P contributed to the loss of the risk allele. Briefly, using IZV and HLA typing data, I confirmed that two loss-of-function mutations were located on the 0201 risk allele. So I concluded that both UPD6P and loss-of-function mutations canceled risk allele at the single-cell level. Lastly, to show clonal stability, I'm going to show these cases with two different time points. First case is a 10-year-old pediatric patient with RCC. At diagnosis, this patient already had one HLA-B loss-of-function clone and two different UPD clones. The patient was treated with IST, then he did not require any additional treatment. The sample at 8 years after diagnosis showed an increase of one of the UPD clones, UPD2. These findings suggested that the increase of UPD clone 2 contributed to recovery from bone marrow failure. Then the last question is, what clonal changes confer increased long-term fitness? So I evaluated the cell of origin of these clones. This figure shows the normalized read count of the representative cell surface markers in Y-type UPD clone 1 and 2. As you can see, the expression level of CD34, a marker of force HSPCs, was significantly higher in UPD clone 2 compared with the others. These findings suggested that in UPD clone 2, UPD occurred at early stage of HSPC differentiation, which increased long-term fitness. The last case is an adult patient with refractory aplastic anemia. In the sample collected at time point 1, after 2 courses of IST, the patient already exhibited 20% of TET2 clone and 9% of UPD clone. 3 years later, the patient was still refractory and CBC did not show improvement, but TET2 clone had increased to almost 50%. So I evaluated the cell of origin of TET2 clone. So as you can see, the expression level of CD34 in TET2 clones was significantly higher than the others. In addition, we observed high expression of CD11B, a marker of the mirrored lineage within the TET2 clone. These findings suggested that within the TET2 clone, mutation likely occurred during the early stage of HSPC differentiation. Consequently, owing to the mutation, the clone exhibits a propensity towards myeloid differentiation. So to summarize, most somatic alteration in aplastic anemia arose as independent clones. HLA risk allele was cancelled by multiple HLA loss alterations at the single cell level. Somatic alterations at early stage of HSPC differentiation improve long-term fitness. Lastly, I'd like to acknowledge everyone involved in this study, especially my mentor, Dr. Marcin Wardowski, and all of the collaborators, and of course, all of the patients and parents. Thank you for your attention.
Thank you very much. So our next speaker is coming in remotely. So this is Dr. Hiroyuki Takamori from the University of Tokyo, who will be speaking to us regarding somatic mutations in PNH.
Hello, can you see my slide?
Yes.
Yeah, thank you. First of all, I'd like to express my sincere gratitude to the organizers of this symposium. It is a great honor to be able to speak to you today. I have no financial disclosures. I'm here to talk about somatic mutations in PNH. I will first give a little background, then I will tell you about my current research titled Inferred Trajectories of Clonal Expansion in PNH. First, I'd like to talk about the most responsible mutations in PNH, PIGA mutations. PIGA participate in the first step of GPI anchor biosynthesis. Since PIGA is located on the chromosome X, one hit of PIGA mutation results in the deficiency of GPI anchor proteins. PIGA mutated clone did not show intrinsic growth advantage in several experiments. Which components of HSCs or HSPCs acquire PIGA mutations may determine the fate of PIGA mutated clones. Similar to other diseases, next generation sequencing have revealed the pathogenesis of PNH. Here is a great work from Cleveland Clinic. They did deep sequencing of PIGA gene of PNH patients. They found multiple PIGA mutations were common in PNH patients. In addition, they showed the types of PIGA mutations affected the expression of GPI-anchored proteins. Recently, Dr. Kinoshida's group identified PIG-T or PIG-B mutations in PNH patients with autoinflammatory features. PNH patients with PIG-T or PIG-B mutations can make free GPI without proteins. And they show that free GPI may facilitate autoinflammatory features. For hemolytic PNH, multi-step theory has been proposed. After immune attack, additional mutations in genes other than PIGA may drive clonal expansion of PIGA mutated clones. HMGA2, JAK2, and BCR-ABL1 were observed in several PNH patients. However, PNH patients carrying driver mutation may be rare. Here is a pivotal genetic study on PNH patients from Cleveland Clinic. They found that heterogeneity of mutation profile and clonal architectures. Complement inhibitor improves the life expectancy of PNH patients. However, patients with PNH require lifelong treatment with complement inhibitors. We need to clarify the pathogenesis of PNH leading to cure of PNH. One of the things that we don't know about PNH is the clonal history of PIGA mutated clone before the diagnosis. Recent studies have focused on the pathogenesis after the diagnosis of PNH or other bone marrow failures. And then we try to figure out the clonal history of PIGA mutated clones before the diagnosis using phylogenetic tree analysis. Here, I'd like to talk about a brief overview of phylogenetic tree analysis using hematopoietic cells. This method was established by Sanger Institute. A phylogenetic tree is a diagram showing a pattern of ancestral and descendant relationship. In our studies, tips of the branches represent single-cell derived colonies, which works as a surrogate for its parent hematopoietic stem cell. A branch represents mutations, and the length of branch reflects the number of mutations. The mutations identified by whole genome sequencing are assigned to branches. A set of lineage descending from the shared ancestral branch is inferred clade. Branch point shows symmetrical cell divisions of ancestral HSCs. A recent study have shown that every hematopoietic cell acquires 17 mutations per year constantly. Most of these mutations, called passenger mutations, do not affect protein functions and can be used as a molecular clock. Based on these findings, branch length is converted from the number of mutations to time. Using these trees called time-based trees, you can infer when driver mutations occurred and how quickly clones expanded. Before whole genome sequencing, we grew single-cell derived colonies because we need plenty of DNA to perform whole genome sequencing. I'd like to move on to my results. We performed phylogenetic tree analysis on 2 PNH patients. Case 1. The patient was diagnosed with aplastic anemia at the age of 28 and was observed without medications. He reported dark urine at the age of 40. He presented to our hospital and was diagnosed with PNH at the age of 45. In terms of clonal architecture, we found 5 independent PGA mutated clones and 3 independent BCOA mutated clones. Out of 5, 3 PGA mutated clones formed clades, and out of 3, 1 BCOA mutated clone formed a clade. So we performed further analysis on these clades. Here we estimated when these clades began to expand. All clades were estimated to have started expanding in his mid-30s following the diagnosis of aplastic anemia. This phylogenetic tree is consistent with clonal expansion of these clades facilitated by autoimmune mechanisms. Next, I'd like to talk about hematopoiesis of GPI-positive populations. Recent studies have shown that long and isolated branches in the phylogenetic tree of blood cells indicate high polyclonal hematopoiesis. In this phylogenetic tree, we found expanded clones without non-driver mutations with shared long and isolated short branches within GPI-positive populations. These findings may suggest that hematopoiesis of GPI-positive clones has a loss of clonal diversity. Interestingly, the onset of this expansion was inferred in his mid-30s. Next, we looked at his phylogenetic tree from a clinical point of view. We also observed that before he experienced the hemoglobinuria, his platelet count showed the lowest number and subsequently recovered. Here is one of the possible models for clonal evolution in aplastic anemia. The recovery of hematopoiesis after immune-mediated bone marrow destruction might confer the growth advantage to residual stem cell called the bottleneck effect. The clonal expansion of non-PGA mutated clones without known driver mutations might represent bottleneck effects. Here we estimated mutation rate. PGA mutated clones acquire more mutations than non-PGA mutated clones. These results may reflect differences in cell division history, suggesting the growth advantage of PGA mutated clones. I'd like to move on to case 2. At the age of 33, she was diagnosed with aplastic anemia with normal karyotype. She was treated with anabolic steroid. 5 months later, karyotypic abnormalities involving HMGA2 genes was found in 3 of 21 metaphase cells. At the age of 34, she reported hemoglobinuria and the diagnosis of PNH was established. Here is her phylogenetic trees. We found that all PGA mutated clones harbored HMGA2 mutations. This result is consistent with our previous results. So we could not determine the order of acquisition of PGA mutations and HMGA2 mutations. Here I will talk about the timing of clonal expansion. She had normal complete blood count before the diagnosis of aplastic anemia, but we identified that PGA mutated clone began to expand over 10 years before the diagnosis of aplastic anemia. These findings give us 2 hypotheses. First, PIGA and HMG2 mutated clones may expand without the setting of immune abnormalities. Several studies reported that HMG2 mutations conferred growth advantage to PIGA mutated clones in mouse model. Second, the immune abnormalities might have already occurred despite the normal blood count. Finally, we infer the dynamics of the effective population size of PIGA mutated clones using phylogenetic analysis. In this context, the effective population size means the number of PIGA mutated clones which produce daughter cells. Here is the clonal dynamics of effective population size. PIGA mutated clones seems to expand gradually from when she was 21 years old until her diagnosis. Here is a summary. Our study has several limitations. We could not determine when PIGA mutation occurs, and several clades had a few clones. But our findings emphasize the heterogeneity of the pathogenesis of PNH. Finally, I would like to express my great thanks to the patient with PNH who participated in this study. Additionally, I appreciate my colleagues and collaborators for their great work throughout this study. Thank you so much.
Thank you for your great talk. And finally, we will move on to the final speakers. Dr. Maki Sakuma from MLL, and her title of her talk is a somatic mutation in Vexas. So could you start?
Thank you very much for this invitation. I'm very honored to represent MLL Munich Leukemia Laboratory to talk about somatic mutations in Vexas. So Vexas was described in late 2020 to be an adult onset hematoinflammatory disease of males caused by somatic mutations in the X chromosome gene UBA1 in the hematopoietic stem and progenitor cells. Vexas patients develop cytopenias, and 24 to 53% of Vexas patients are diagnosed with MDS. And in general, approximately 30% of MDS patients progress to AML, but Vexas patients almost never progress to AML. So some experts consider Vexas MDS to be a unique subgroup of inflammatory clonal cytopenia. Soon after the initial description of Vexas, mutations outside of the originally identified M41 locus has been reported, and preliminary research suggests that there are some clinical differences. And in fact, there are clinical differences among the canonical variants. UBA1 is an essential E1 enzyme in the ubiquitin proteasome pathway and exists in both nucleus and the cytoplasm. The canonical M41 mutation is a loss of the cytoplasmic isoform, but further research detected some very small amount of cytoplasmic isoforms in the mutated cells, and this amount differs amongst the variants, where the M41V variant has this least of these residual cytoplasmic isoform. And clinically, M41V is worse prognosis, and M41L is probably best prognosis. The UBA non-M41 mutations are partial loss of function mutations of both the nuclear and the cytoplasmic isoform, and clinically, some reports suggest that they are less inflammatory or that the cytopenias are worse, but too few cases are known to conclude anything. And this is where MLL can contribute, because MLL is very good at collecting samples. So MLL is a leading diagnostic company in the field of hematology in Germany, and MLL introduced UBA1 entire coding sequence in the routine myeloid panel since July 2022. We received samples from all over Germany as well as internationally, and we sequence approximately 1,000 samples for UBA1 sequencing per month, and we obtain approximately 6 M41 and 4 non-M41 positive samples per month. And by February this year, we sequenced approximately 22,000 samples, and the majority of these samples undergo other leukemia diagnostic testing at MLL to reach a diagnosis. And so here we have a very large, well-characterized cohort of symptomatic patients with UBA mutation information available. So our data can offer a comprehensive view of the hematological manifestations of UBA mutations in comparison to the better characterized mutations. So quickly over the processing of the variants. So we have these 22 samples, and then we filter out the wild type and the known non-pathogenic variants registered in various databases. The M41 variants are identified regardless of the VAF, and then the rest of the variants are classified into these 4 categories, and mainly based on sex and variant allele frequency. And we focused in this study on the somatic male variants because we're not so sure of the pathogenicity of the female variants. So we first looked at how the patients are diagnosed. So as we know, the M41 variants are either not diagnosed of any defined hematological malignancies or MDS, and this made up to 94% of the patients. We had 100, so 5 patients for multiple myeloma, MGUS or MBL, and then we had 1 MPN patient, but this MPN patient was diagnosed of MPN before, and then was sent for myeloid gene panel due to new onset cytopenias. And then there are at least 3 similar case reports of the later acquisitions of M41 mutations in MPN patients. In contrast, for the non-M41 variants, only 51% of them were not diagnosed of anything, and then the proportion of MDS patients were similar, adding up to 72% in comparison. And interestingly, for the non-M41 variants, we observed some patients with AML as well as lymphomas. So here we see that these 2 classes of UVM variants are very distinct hematologically, but what we were interested was how does this composition compare to the better characterized mutations. So we, as I mentioned, we processed these 22,000 samples, and these go through different kinds of leukemia diagnostic standard tests to reach a final diagnosis. I showed the data for the UBM positive patients, but these patients also go through up to 65 gene sequencing. So in principle, we can do the same thing for all these 65 genes. And our question, one of our questions was whether this 71% of the patients not diagnosed of anything, is this a high percentage or not? Because we know that, for example, DNMT3A and TET2 mutations can be detected in asymptomatic patients. So we did the same analysis for the 4 genes frequently found in CHIP. And so for the patients who were had harbored the DNMT3A mutations, the percentage of no diagnosis was 51%, and this was the highest among these 4 genes and similar to the non-M41 variants. And then TET2 was 45, SF3B1 35, JAK2 11%. So this 71% of the patients not diagnosed of any hematologic malignancy is indeed a high percentage. And so the M41 variants are quite distinct from the leukemia-associated genes that we know. And the non-M41 variants at 51% is well, not out of the ordinary to be on leukemia-associated genes. So our next question was, how is this diagnosis affected by variant allele frequency and co-mutations? So these are the VAF histograms of the M41 and the non-M41 variants, the patients. And in the color, you see the number of co-mutations the patients harbored in 31 selected genes from the myeloid panel. And blue is no commutation, green is 1 commutation, orange is 2 commutations and over, and gray are the patients that we did not have all the data for the 31 genes, either due to quality control or due to specific requests. And we see that for the M41 variants, we see a tendency of a bigger clone, and in fact also less commutations, as you can see from this predominantly blue histogram for the M41 and the predominantly orange histogram for the non-M41 variants patients. And then we also noticed that this orange part, so the patients with more commutations are more likely in patients who are harboring smaller clones compared to the patients who are harboring bigger clones. And then this tendency was not observed in the non-M41 patients. So these are the 3 VAF groups that we created, and then we looked into the diagnosis. So for the M41 variants, we see that regardless of the VAF, the majority of the patients are either not diagnosed of any defined hematological malignancies or MDS, and if anything, the non-MDS diagnoses are more often seen in the patients with a smaller clone. And also, if we look into the average number of commutations per entity for the M41 patients, we see that these non-MDS patients have higher number of commutations. And we looked into the non-M41, and then the situation is different for the non-M41 patients, and we see that the higher the VAF, the less likely it is that the patients aren't diagnosed of anything, which is kind of sort of what we expect for genes to be associated to leukemia. So I'm sure most of you have seen this figure before, where for the early mutations such as TET2 and DNMT3A, we think that the growth of the clone size and the chances of getting co-mutations increases as time passes. And we've shown the cross-sectional distribution of these entities in the early mutations, which supports this model. But in the case of UBA and M4 mutations, we do see the growth of the clones, and but however bigger the clone becomes, the chances of co-mutations is not that big, and also even if they do gain co-mutation, the diagnosis is at most MDS in 94% of the cases, and when they do gain co-mutation, they tend to be in the early stage, or that the M41s are a second hit. So now let's look a little bit on the cases that we do have co-mutations, and in this analysis we limited to the male patients, because we know that sex is a significant confounding factor in co-mutation analysis. And so we looked into the 86 M40 male patients who we had all the data for the 31 genes that I mentioned before, and 29 of them had at least one co-mutation, and the top co-mutation is DNMT3A, followed by TET2, and then the percentage drops quite dramatically. And what we wanted to know was is this 15% high or low? And so we compared with the patients who harbor mutations in TET2, DNMT3A, SRSF2, SF3B1, JAK2, ASXL1, and to the male average. And we see that 15% of, so the M41s are in red, as I showed already on the left. And we see that the percentage of patients harboring co-mutations with DNMT3A, 15% is comparable to patients harboring SF3B1 mutations or to the male average. However, 13% of the patients harboring co-mutations with TET2 is already less frequent than the male average. And the rest of the co-mutations are also less frequent than the male average, and also to patients harboring the 6 G mutations I mentioned. And so then we looked into the VAF plot, and then we see that it's really only DNMT3A and some of TET2 where we see the two mutations coexisting in the same clone. And then all the other ones, except maybe EZH2, we don't really see that these clones achieve high VAF in the presence of M41 mutations, which is consistent with what has been observed by Dr. Gutierrez Rodriguez. And for the non-M41 variants, we don't see the same thing. And for example, with ASXL1 co-mutation, we see that ASXL1 is probably the first hit, and then the clones can grow together. So we observe that the M41 mutations are very low-risk mutations oncologically, but we also know that the M41 mutations are very symptomatic, lead to cytopenia, and that the cytopenias are progressive. So we wanted to see the relationship with the clone size, and this is the bone marrow differential counts by VAF. And we see that total granulopoiesis, which is the sum of all the granulocyte progenitor cells, progressively increases, and total erythropoiesis progressively decreases as the VAF becomes greater. And we also see a progressive decrease in hemoglobin and platelet as the VAF increases. And again, we don't see the same thing for the non-M41 variants. However, we do see worsening of anemia and thrombocytopenia as the VAF increases, even though we see increased erythropoiesis in some of these patients. So we saw that for the non-M41 patients, there are patients who have anemia despite increased erythropoiesis. So we wanted to know what's happening in the erythroid lineage. And so we looked into some of the popular erythroid dysplasia parameters, which are reduced CD71 expression in flow cytometry and ring cereblastin morphological analysis. And we ranked again the patients harboring the 31 genes based on the percentage of the patients who show these changes. And we see that for both of the parameters, SF3B1 is top, but we also see that the non-M41 also comes in the higher percentage side, and then the M41 patients are less likely to show these clear dysplastic changes captured by these two parameters. To summarize, UBE1 M41 variants seem not to accelerate the acquisition or clonal expansion of the co-mutations compared to commonly mutated genes and are often non-malignant. UBE1 M41 clone size seems to be associated with increasing myeloid bias and progression of cytopenias. UBE1 non-M41 variants behave like other driver genes in the acquisition or clonal expansion of other co-mutations and have a higher risk of progression to malignant entities compared to the M41 patients. And the mechanisms of anemia in UBE1 M41 and non-M41 variants seem to be different. This is the end of my talk. Thank you very much for your attention.
Great. Thank you very much. So, any questions? Yep, Yar.
Beautiful talk about Vexas. My study, based already on the discovery, was the fact that actually the nomenclature is still not clear, right? Because most of the Vexas, you studied actually ring xeroblasts, but what is the number of the vacuoles, right? Vexels are, so can you call it Vexas if there is no vacuoles, right? But people send to MLL samples because of a reason. This is not like random. I didn't send my sample to, right? But you had still a lot of patients without diagnosis, right? So if you subtracted, the frequency of Vexas detection would be approximately 0.5%, right? Because roughly 1/3 were asymptomatic completely. So among symptomatic patients. So if you take the UK Biobank or all of us, which by the way, they are meeting here in this room usually, what is the frequency in general population of the 41 and non-41?
So for the non-M41 that I know that are pathogenic, it's almost 0%. And M41, I think Dr. David Beck had this study, it was 1 in 4,000. So definitely if you look for the patients who are sent to MLL, the frequency of these M41 and both non-M41 variants are much higher. And if I may also add, Dr. Beck also had this study of looking into the highly inflammatory patients of M41 and non-M41, and then the M41 was like 40%, and then but the non-M41 was like 2 or 4. It was 2 or 4 cases. I'm sorry, I don't remember the exact. But the thing is that if you look into the inflammatory patients, the ratio of M41 to non-M41 is 1 in 0.2 or something like this, but then in our case it's 1 in 0.7 or so. So the non-M41s are a lot higher in our cohort, probably because they're not as inflammatory as the M41s. But we don't have much of the rheumatological data to really show this, but this is what I think.
Thank you.
1 in 4,000 old white men.
Yes, exactly.
Oh, okay.
So I guess just MLL in general, so the kind of, the samples you get referred, are they usually from hematologists, and it's kind of, that's
yes,
the
so we get the samples from the hematologists, especially I guess that those hematologists who don't have access to their own lab. And I heard it's 80% of the leukemia samples come to MLL.
Okay, in Germany. Okay, cool.
I have a question for Dr. Huuhtanen. Beautiful, beautiful talk and very nice work. How do you distinguish between passenger mutations that occur normally in lymphocytes and then dividing and sort of accumulating over time because of their longevity and long proliferative history? And then you have, let's say, a pathogenic insult, and you have, due to the T cell receptor, you have activation of the T cell unrelated to the passenger mutation, expanded in the clone and then recovered in the study as a VUS, right? How do you distinguish the sort of a driver mutation that really, truly has some impact on that lymphocyte behavior from just normal expansion?
Yeah, I think that is one of the big questions that we don't currently have the good answer for that. So like with any other case of like what is driver and what is passenger mutation also applies to here. Perhaps in this scenario we don't have the privilege of having a large database of what is a driver mutations for T cell expansion and whatnot. So it's a bit more complicated. Most of our studies done nowadays are based on these like immune panel, where researchers have tried to compile a list of known mutations in different lymphoid neoplasias and such. So perhaps that might offer some clue, but often it doesn't. So it's still something that we struggle with, and as the research area gets more interest, and perhaps then we will truly find out what's going on. One of the things is also that these mutations are often quite private to one patient, so we don't have like a huge hit like we did with the LCL leukemia. So often these are not recurrent mutations. So validating them in vitro, like what is their function, it's been a bit hindered by that because we don't have a good lead where to follow.
Hello, great session. I have different questions for different speakers. So for first one, Dr. Sakuma. So my question is, based on your data, you basically have 1 out of 200 patients, you're gonna find a UBA1 M41, right? Because it's roughly 100 patients out of 22,000 that you screened?
So I calculated with the percentage, 0.6% of the patients who get referred to MLL we have M41 positives. Because we screen 1,000 per month, and then we get on average 6.
So yeah, so it's 1 out of 200 patients, you're gonna find a UBA1 mutation, the canonical one, which is much more like frequent than the 1 to 4,000 that David Beck reported. So my question is, do you think that this is because of the limit of detection, so the sensitivity of your assay? So what is the frequency of these UBA1 mutations that you see usually? Because, for example, in Vexas, patients that have clinical manifestations, usually they high VAF.
Yes.
So in your cohort, they are small clones that you picked it up basically because you're using deep sequencing, or they're always high?
I think it's because of the samples that get sent to us. They have to have a symptom to be, we don't sequence asymptomatic patients, individuals. We sequence patients who have cytopenia, monocytosis, some sort of hematological manifestations, and this is probably why that we have higher incidence. And I think the lowest BAF that we have was like 1.8% or so. Okay. So it's not too low.
Not too low. And you also showed the SF3B1. That was with UBA1 mutations or no?
No.
Ah, okay.
Everything is independent.
Independent. So the one you have UBA1, the most common mutations were DNMT3A and TAT2.
Yes, just as you described.
Yeah, okay. Thank you. And the second question is for Dr. Yoshida. The single-cell DNA panels that you did. So I saw in your table that you didn't look that many PGA with 6PLOH. I think it was only one case. Is that true? So because we think that both are adaptive, like we both are kind of like an immune escape, how often they co-occur in the same patient?
So you mean the PQA and UPD6B?
Yeah.
So I have to double check my table just a moment. Sorry, I couldn't remember the exact number. So co-occurrence was only, yeah, you were right, only one case showed the UPD6B and PQA. And our cohort is not like a screening cohort. Like we already chose some samples with multiple alterations, so I can't say that it's a general population's mutation frequency.
Okay, thank you. And the third one, sorry, just one more. And to Dr. Takamori, how difficult it was to grow clones from aplastic anemia patients for your whole genome sequencing?
Sorry.
So how difficult it was for you to get colonies enough to do the whole genome sequencing from aplastic anemia patients? Because even our hands, it's really hard, even though the patient have recovery and...
I have difficulty to obtain plenty of DNA from single-cell derived colonies. Actually, we picked more than 100 colonies from each patient, but I could get enough DNA from only roughly about 50 colonies. Yeah.
I wanted to just follow on Simona's comment about the terminology that we use for evolution. Maybe we can settle this at lunch, but it's still quite confusing. And there's a history. I mean, clonality, you recall when we did that some people think that if you have clonality, that means you have cancer. That's clearly not true. We talk about benign clones, we talk about malignant clones, mutations that demarcate cancer supposedly can be found in adjacent cells in the tissue like the esophagus or stomach. So even having all of the wrong mutations doesn't mean that you have cancer just because there's some tissue adjacent. Evolution is, I mean, there's evolution. There's evolution in all patients, right? There's a change in the clones, and we would call that evolution. It's not drift, it's being selected. So I think, I don't necessarily have the answer, although obviously we prefer the idea of deriving the terminology from what we're observing. That's not the only way to do it, but I think Emma and others have shown there are high-risk changes that occur in aplascanemia and low-risk or zero consequence changes. We should agree on how we talk about this. It's confusing to each other, and I think it's confusing to patients.
It will be even more confusing when we add things like heteroplasmy. Yeah. You know, now that it's coming on as a measure of clonal and the correlation. In fact, there was recently a very interesting story showing that heteroplasmy, which is a marker of clonality, does not mean anything, but the people who had a clone, chip clone, and heteroplasmy, these are the ones that had 10 times higher risk than people who had one or the other, right? I mean, very interesting story, yeah.
Yes, actually, this is the never-ending discussion that we may keep for lunch and maybe even better dinner tonight. But I mean, going back to cells, I have a question for Dr. Takamori. So when you were describing the PNH data, you showed that, you know, the number of events, if you like, is lower in normal, non-PGA mutated cells. But I think you cannot take in consideration the number of successful divisions, because in the end, I mean, what is driving mutation are the cell divisions. And if you assume that normal cells, cannot divide as efficiently as the PGA1 just because of the immune pressure, of course, the number of events is lower. So this is not entirely associated with the PGA mutation itself. It is just a result of the different environment that you have in the bone marrow. And this is just, to highlight once again that even what we are used to call driver mutation are not necessarily driving anything. It's like having, a driver with all one-way streets. So, I mean, you are going in that direction, well, these are random events. You cannot predict. And all the PNH patients that you show are really individual. You cannot predict anything. You are just describing what is happening. This is great biologically, but unfortunately, we cannot predict something which remains highly random, in my opinion.
Yeah, thank you so much. I totally agree with your opinion. Yeah, we haven't do experiment about molecular. We haven't did molecular experiment. So I'm not sure what happened. Yeah. So yeah, exactly. Thank you so much for the comments.
I have a question for Dr. Huuhtanen. Fascinating lecture. I have many patients with LGL clones, and I'm struck by how heterogeneous that situation is. Some have thrombocytopenia. I saw a patient from China yesterday that has a clone and has been treated for ITP for 20 years. I have some patients that have aplastic anemia and many that have nothing. Do you have any insight into the heterogeneity? I was very struck by the exhaustion issue. Is this environmental? Is it genetically driven? Do you have any hint on why this is such a heterogeneous disease?
Yeah, that's an excellent question. When people are studying single-cell transcriptomics, I think everyone is having a title that single cells reveals heterogeneity and such. In the case of LGL leukemia, I was perhaps a bit surprised that we didn't see that much heterogeneity based on the transcriptome of the LGL cells. Yeah, clinically they are really, really different, and we can have interesting cases where there is like T cell proliferation concomitant with B cell proliferation. So it might be that the thing that we denote that LGL leukemia is from the mature T cells might not be the case. Actually, it might be that the cell of origin might be more premature. Based on your questions, like what affects the clinical heterogeneity, of course, these mutations have been somewhat associated with different types of clinical pictures, but I guess there must be something also in the targets that T cells recognize, so that might also influence, like, is the target, like the TCR can be quite permissive in its targets, unlike, for example, B cell antigens, which are quite specific to their target. If an LGL clone recognizes like 10,000 targets, I would expect that that patient would have far more issues than a patient whose TLCL clone's TCR is restricted to like 10 antigens or so. But I think one of the most interesting things about LGL leukemia is also like who are the healthy individuals who have these LGL cells and they don't have any symptoms. So what is going on with those patients as well, or healthy individuals, I'm sorry.
So I want to offer a perhaps simplistic, but this is a conversation I had with your boss during the pandemic. I mean, the assumption is that these mutations, of course, are occurring all the time in the immune system, as they're occurring all the time in the hematopoietic system, and they need to be selected. And it's actually easier to think in the immune system why they get selected. There's got to be an engaged antigen. And I think it's the nature of the antigen with these random mutations that, in the instance of STAT3 and others, increase T cell activity that determine where the disease, if there's disease at all. I mean, after all, there are LGL populations in aging people who we don't think have anything to do with disease, and presumably that's because they recognize an antigen that if you kill those cells, or there are other cells that control it, intercellular, T regulatory cells, lots of things that would dictate it. But at the first level, it's what is the cognate antigen that mutated cell is going to recognize. And most of those mutations are benign because you never see the cognate antigen.
Well, but the VAFs are very small of these subclonal mutations, subclonal to the TCR.
Yeah.
Clonal TCR. So this does not explain everything. But, you know, when I offer an alternative to it would be the fact that it happens in the context of inability to clear the antigen, and you know, and by this virtue, hyperplastic, if you wish, response that is hypercompensation, let's say, to inability to produce antibodies. So we see LGL in combined variable immunodeficiency. We see LGL after patients were treated with Rituxan for CLL. Many have hypoglobulinemia to begin with. Many patients have hypo-IgA, and so on. So, you know, there is another dimension to it. What does recognize?
Yeah, no, I think that's correct, and there are many dimensions. And there's this paper that just came out in Blood on herpes viral antigens that are recognized by T cells. This is a German group. You know, they have a beautiful pipeline for looking at antigens, which antigens. So that, you know, there are a number of patients in detailed studies of T cells and aplastic anemia where the T cell response is against the herpes virus. And the problem there is with the herpes virus, you're never going to run out of the antigen. And if it's cross-reactive, as they suggest in that paper, with a normal cell's repertoire of what's presented as an antigen, you won't run out of those antigens unless you create aplastic anemia either. So I agree with what you say, but it's going to get, it is complicated in terms of what's the driver, what's just a component, and so on.
So it boils
That's going to be important.
All right, and on that note, it's time for lunch. Thank you all.